Well, I'm delighted to be here and honored to be among such a distinguished group of both presenters. And thank you all for coming. Um, I think when we turn to the topic of health disparities, so we turn to the issue of racial health disparities. Certainly, racial health disparities are profoundly large. They appear to widen over the life cycle and are very suggestive of an important role of childhood conditions. At age 25, there's a 5 year life expectancy gap between blacks and whites. And more than half of that disparity in longevity is due to higher prevalence of risk factors related to cardiovascular disease. When we think about cardiovascular disease, deaths related to heart disease are almost twice, 2 to 3 times higher among blacks relative to whites. We see that every 7 minutes, a black person dies prematurely in the US. That translates to over 200 black people dying daily who would not have died if the health of blacks and whites were equalized. Now, this isn't just driven by individual level and contemporaneous individual family level factors. In fact, white high school graduation, I should say, in fact, white high school graduates who did not attend college live longer than blacks with a college degree or more education. And so while these health inequalities have been well documented, they're not immutable. They are not the product of genes, but the product of our policies and our history. And so I am going to summarize some work that has the aim of looking back to point the way forward. The argument here is that the keys to unlock healthy development and best promote health equity lie in the historical evidence on the long run effects of some of the key policy interventions of our time. And part of that has to do with this biosocial model of racial stratification that begins in childhood, but over an extended period of time, the degree of segregation, the degree of socioeconomic inequality, the concentrated exposure to poverty and violence leads to high allostatic loads that lead to greater risks for coronary heart disease, inflammatory disorders, and cognitive impairment. And so what I do to study this role of childhood conditions on adult health is to first document the proportion of current adult health disparities that are rooted in early life factors, and document the dynamic complementarity in human capital investments, and to highlight which particular childhood, family, and neighborhood factors matter most. And to do this, I'm analyzing the health trajectories over the life course of people born between 1945 and 1975, but who've been followed through 2015 through the Nationally Representative Panel Study of Income Dynamics. And importantly, I'm going to use the introduction of Medicaid and its rollout as a shock to early access to health insurance coverage, using a difference in difference approach and estimating, therefore, the long-term returns to Medicaid spending and how much it narrowed racial health disparities. And then I'll close with implications for contemporary policy. Now, this work comes from the Panel Study of Income Dynamics that spans more than 4 decades. We're talking about over 13,380 children, the oversample of Black and low-income children, and then attaching the residential address history so that I can characterize the childhood conditions that prevailed when they were growing up. The key results are, first, we document that hypertension and diabetes rates are 2 to 3 times higher among Blacks, but that explains their higher burden of cardiovascular disease, which is the leading cause of death in the US. But importantly, that these racial health disparities are driven primarily by racial differences in childhood conditions, that parental income, access to child care in childhood, neighborhood poverty, and other child, family, neighborhood factors are instrumental in narrowing these gaps, that we see and document significant childhood Medicaid spending effects on long-term child health and adult outcomes, including reductions in the incidence of low birth weight, improvements in child and adult health, increases in educational attainment, increases in income, reductions in the annual incidence of poverty in adulthood, And all of those pieces collectively significantly reduced racial disparities. When we look at the cumulative mortality hazard over the life course, and in this work, I'm focusing on black-white differences primarily because for other racial and ethnic groups, I don't have sufficient samples, sizes, to look at racial and ethnic differences for Hispanics and Asian. But when we look at the kind of race differences in the mortality hazard, as shown here, and particularly looking at those differences in some of the leading risk factors for mortality, like the onset of hypertension, we see that those things open up, where by age 50, more than 3/4 of African Americans have been diagnosed with hypertension, more than double that for whites. Okay, but importantly, when we compare black and white children or adults who were exposed to the same childhood experiences, the same childhood conditions. That is, when we control for the child, family, neighborhood factors, neighborhood poverty, family income, parental education, the kind of extent of concentrated crime in the neighborhoods, et cetera, all, from birth to childhood, we just focus on those factors alone, that when we look at the hazard of the onset of hypertension, we see differences that are in green much closer to what we actually see for whites. That is, when whites and blacks are exposed to similar childhood conditions, we actually see the racial health disparities are much, much smaller. In the case of the cumulative hazard of onset of stroke, heart attack, or heart disease by race, we see the black-white differences here between blacks and whites are enormous. But again, when blacks and whites are exposed to similar childhood conditions, we see no distinguishing difference in the actual onset of stroke, heart disease, and heart attack by race. Now, what's remarkable about this is that these differences that we see rooted in childhood conditions, when we compare contemporaneous socioeconomic factors like education and income in adulthood to try to account for these adult health disparities, racial health disparities, the contemporary adult socioeconomic factors account for relatively little of the gap, whereas the childhood conditions account for the vast majority. Now, I'm going to, again, looking back to point the way forward, to look at the long-run effects of childhood Medicaid spending using the introduction and staggered introduction of Medicaid implementation to look at long-run impacts. What's important about this is that the greatest black-white convergence in various dimensions of health over the life course occurred for cohorts born between 1965 and 1980. This period coincided with the rollout of Medicaid, school and hospital desegregation, and Head Start. Each of these policies substantially improved early life health and led to educational investments that in turn narrowed opportunity gaps between minority and poor children. And these policies remain very important today. We can see that in Medicaid, for example, that covers roughly nearly 44 million children, covering 1/2 of low-income children. Now, what I do, again, to go back in time, first to frame, this is a map that has a similar geography of the concentration of poverty as was presented in the early session, but what's different is that the concentration of poverty in terms of the levels was much more acute. In the dark red, that's counties in which more than 45% of households are poor, okay? Now, the timing of Medicaid implementation, while it was part of Lyndon Johnson's war on poverty, there was a staggered timing. So I'm going to show you a map of the staggered timing because what I'm going to use in terms of the research design is the timing of Medicaid implementation and cross-state differences in Medicaid eligibility that were benchmarked to pre-Medicaid state AFDC levels. I'm going to use those as variation to isolate child health insurance coverage differences across cohorts. So this is the map of Medicaid implementation 1965. That's the rollout. This one state, 1982. They were late comers, okay? Oh, wow, okay. I don't know what happened here. Okay, so there's a little graphical issue, but what you should see is that pre-Medicaid implementation, there was substantial state AFDC rate differences, and the Medicaid eligibility parameters were benchmarked to these state AFDC rates. So you would have children that were otherwise similarly poor, but grew up in states with very different Medicaid eligibility. This is for all children, But because Black children were disproportionately poor, their state AFDC rates are an order of magnitude different. So what I'm going to be doing is using that state variation in the generosity of Medicaid eligibility to then exploit the staggered introduction of Medicaid across states, the cross-state variation in Medicaid eligibility, and to isolate the causal effects of access on these outcomes, comparing children in areas where Medicaid isn't available with children in those same areas after Medicaid became eligible. So it's really the changing availability of health insurance coverage beyond the role of parents. And basically, what those results show is not only did post Medicaid cohorts have significant increases in their public health insurance use, but the increases resulted in significant increases in educational attainment that were much more profoundly improving in among children from high eligibility states. So we don't see this kind of significant uptick, though in the pre-Medicaid rollout period, basically a similar trend leading up to the Medicaid rollout. So in sum, because I'm out of time, the take home is that what we see from this is that racial health disparities are not immutable. They're strongly influenced by education and health policies that influence childhood conditions. We see significant long-run returns to Medicaid spending that did reduce racial health disparities, and that the racial health disparities in adulthood are driven primarily by childhood, family, and neighborhood factors. And in conclusion, let me just say that I think what's very clear about some of this work is that contemporary policy should consider the long-term educational, health, and economic benefits of these improvements in infant health that came through Medicaid in light of the present contentious debate surrounding its potential repeal and replacement. Thank you.